Okay, hi everyone. Welcome to our 13th session on the OSCE Masterclass series. Today's session is on data interpretation. We're focusing on CT scans and looking at some blood results. So just a quick introduction. I'm Yurissa. I'm currently a clinical research fellow. I previously worked in A&E and neurosurgery, as well as a variety of other specialties. And I'm joined by Logan.
Hi everyone.
Logan will be taking you through blood results. If Logan, you just want to introduce yourself.
Yeah, hey everyone. Currently working in A&E in London. My experience includes intensive care, medicine and surgery as well. And yeah, excited to take you through a few blood tests, interpretations, and hopefully it's a useful session for all of you.
Okay, so in the chat, Logan will just put in a link to our feedback form. So if you fill in our feedback form at the end of the talk, you will also receive a certificate of completion. And then you will also receive emails with regards to our future talks. So please try and fill that feedback form in at the end. And just another heads up that this talk will be and is being recorded and will eventually be put onto YouTube if you missed any parts of it. Okay, so we'll start with just the background of what we're doing with this specific masterclass series. So about 2 weeks ago, we had a talk on ECGs and ABGs, and that is up on YouTube if any of you missed it. During the next talk, we'll be looking at imaging, so chest x-rays, abdominal x-rays, fractures, as well as a bit of lung function tests, hopefully. And the focus of today's talk is to review CT scans and an approach to how you would review them with regard to an OSCE scenario or station, and as well as blood test interpretation. So yeah, like I've said, we're going to be looking at CT scans and blood results, so common conditions and syndromes. And it'll be quite interactive, and you'll have a chance to practice, and we'll also give you some further links for your own learning. Okay, so we'll start off with the CT scans. So just a few basics. So CT stands for computed tomography. So basically a CT scan involves the use of a series of x-rays which are emitted towards the patient at different angles. And depending on this, you get a different density of the image created. It's actually better than an x-ray because it's a 3D, so three-dimensional view. And if an organ is of high density, such as bone, then it allows more radiation to be absorbed. And so there's less signal detected by the CT scanner, and this makes the image appear white. And then if an organ is of a lower density, such as the lungs, less radiation is absorbed. So there's a greater signal detected by the CT scanner, and basically you'd see a darker image, or it basically looks black. So if you have a look, just get the pointer out. Here, you see that going from, well, my left to right, air is quite dark or black, and as you go down, it becomes lighter and lighter until you get bone, which is white. And this is referring to Hounsfield units, which is the universally used unit used in CT scans. It's a quantitative measure of radio density, and it's only basically used in CT scans. So air has the smallest or the most negative Hounsfield unit quantity. So this is why it appears black. And then as you go down, it becomes more positive, and so bone is white. Just to mention that white matter in the brain is actually darker than gray matter on a CT scan. And this is because white matter is full of myelinated axons. So they essentially very fatty and have a high water content in comparison with gray matter. And this is why white matter looks darker than gray matter on a CT head. Okay, something that's also really important is that you all need to orientate yourselves when thinking about what you're looking at on the CT scan itself. So if you look at this on my left, or probably your right, this is an axial view of a CT brain or CT head. And in terms of an axial view, it's basically the same as a transverse view, or looking basically at a horizontal plane, which is parallel to the ground and divides the body into a top half and bottom half. So top half, bottom half. And then another plane you could get is a sagittal view, which is dividing the body into left and right halves. And then finally coronal, which refers to the crown and basically divides the body into anterior and posterior segments. So you can see that nicely here. Anterior and posterior behind the blue square. So it's just important with regard to every CT scan, so whether it's CT head or brain that you're looking at, or CT abdo-pelvis, to remember which view you're looking at, because it can get pretty confusing if you aren't aware of the views and what organs you expect to see. So we'll start with CT head interpretation. So firstly, in an OSCE, always confirm your patient's details. So make sure you have the correct name and surname as well as date of birth. And then the next most important thing is to look at the date of the CT scan and make sure that you're also holding it the correct way and with the correct orientation. And this is if it's printed out, most likely will be for the purpose of the OSCE. And it's important to look at the date of the scan to also assess when it was taken, and this is relevant in terms of the background history of what's happened to the patient and the indication for the CT scan. A general approach, which I think is quite nice, is using the mnemonic blood can be very bad. So it's BCB, VB. So firstly, starting at looking at the blood, looking for blood, for presence of extra blood or blood where it shouldn't be. They're looking at the cisterns, the brain matter, ventricles, and finally the bone. Other people just do it from outside in. That's also fine. Just do whatever is systematic and a way that you remember to go through each of the different areas of the brain. Then finally, summarize your findings and give your differential diagnosis or diagnosis and a possible management plan. Okay, so I just thought I'd take you through some of the anatomy before we go into the actual steps of interpretation. So here, sorry, if you can all mute yourselves, please. Someone was just getting a call there. So this is the anterior limb of the internal capsule. You can see this, it's a bit darker here. And here, this lighter area is the lentiform nucleus. Internal cerebral veins here, the thalamus, posterior limb of the internal capsule here, it's a bit darker, septum pellucidum in the center here, and then the head of the caudate nucleus, which is slightly whiter. Just going to go to the next slide. This is just to remind you of the different territories when looking at the CT scan. So this is the territory of the anterior cerebral artery, middle cerebral artery, all of the yellow area, anterior choroidal, this turquoise color, and then the posterior cerebral artery, the green, and then the deep perforating lenticulostriate arteries of the MCA. So this would actually be showing MCA infarct, with also involvement of the perforating arteries of the MCA, so lenticulostriate involvement as well. And then just looking at more anatomy, so we see the third ventricle here, basically slit-like structure, midbrain. This tiny dot here would be the cerebral aqueduct, and then sylvian sulcus and corpus callosum. Then moving on, so we're basically going from top down. So we're looking at slices going from superior to inferior. So you see the frontal sinus nicely here. This tiny dot would be the basilar artery, and the pons would lie here, the fourth ventricle here, and here you can see your mastoid air cells, and then middle cerebral artery. Okay, so we'll start with blood. So in our 5-step process of looking at blood, cisterns, brain matter, ventricles, and finally bone. So important things about blood is to just look for anything abnormal you see. The brain needs to look symmetrical. So whatever you see on the left, you should see on the right. And it should be, you should be able to fold that CT in your mind in half, and there should be identical structures on each side. So in terms of an acute bleed would look very bright on a CT scan. And then as the bleed ages, it becomes darker or hyperdense. And then this can take a few hours to 7 days to become hyperdense. And then within the next 1 to 4 weeks, the bleed actually transforms and almost looks quite similar to the brain. So that's why isodense with brain. And then finally, after there's more resolution of that bleed, it becomes hypodense, and then this means it becomes darker, and it generally takes about 4 to 6 weeks for this to happen. So the color of the blood you see is very important because it can tell you when the pathology happened, and if it's something acute or something chronic, or something acute on chronic, where there's different shades of white and gray. I have an example of that coming up. And then in terms of how you can classify hemorrhage, so you can have an extracerebral hemorrhage or extraaxial hemorrhage, or an intracerebral hemorrhage, or intraaxial hemorrhage. So extracerebral is basically just outside of the brain tissue, whereas intracerebral hemorrhage is in the brain tissue itself. And the different types of extracerebral hemorrhage are extradural hematomas. Remember that extradural is the same as an epidural bleed or hematoma. You can also get a subdural bleed, and then finally a subarachnoid bleed or hemorrhage. And then the types of intracerebral hemorrhage or intraaxial hemorrhage are an intracerebral hemorrhage or an intraventricular hemorrhage. So we'll start with extradural hematomas, or like I said, epidural bleeds. They're generally biconvex in shape. They do not cross suture lines, and they usually are resulting from an arterial injury. So for example, blunt trauma to the skull and damage to the middle meningeal artery could result in an epidural bleed. Then a subdural bleed. This is generally crescent-shaped collection of blood. It can cross the suture lines, and it's generally due to venous destruction of the bridging veins. So generally an elderly person with brain atrophy who has head trauma, they are most likely to have a subdural bleed. In terms of a subarachnoid hemorrhage, it is hemorrhage into the cerebrospinal fluid or CSF and the cisterns, secondary to a ruptured aneurysm, trauma, or a ruptured AVM, arteriovenous malformation. And then next, in terms of intraaxial hemorrhage, which I said again is in the brain itself, intracerebral hemorrhage can happen due to trauma, So blunt force trauma to the head, high speed motor vehicle accident, hypertension, so hypertensive bleed or hemorrhagic stroke. And then finally, interventricular hemorrhage. It's generally associated with a significant amount of trauma that causes blood to be present in the ventricles. Okay, so the next part would be to look at the cisterns. So what are cisterns? They are collections of CSF. Their function is to surround and protect the brain. And you need to look at these cisterns for any asymmetry and the presence of blood in them. So the presence of blood in them could lead you to a diagnosis of a subarachnoid hemorrhage. There are 4 cisterns. There's one that's missing. I'm not sure if anyone can tell me which one's missing. It's something that you don't really need to know, but okay, it's fine. So the one that's missing on the diagram is the circummesencephalic cistern. But here we can see the Sylvian cistern, the suprasellar cistern, and then the quadrigeminal cistern. So again, with cisterns, you're just looking at symmetry. So symmetry with regard to this would just be, if you cut it in half, does this half look the same as that half? Does this half look the same as that half? And then just the color of them, do both sides the same color? Is one darker or lighter in a specific area, indicating the possibility of a bleed? And then moving on to the brain matter itself. So there are a few things you need to look at when looking at the brain matter. So we'll start with comparing the sulci and gyri or gyri for evidence of effacement, and then the volumes of the left and right sides. So again, this pattern should be on both sides. So there should be symmetry. So this is the sulcus, so your gyrus, and then the black is the CSF. And then when looking at the brain matter, you also need to look for inconsistencies. So looking at the inconsistencies of the gray or white matter. So we call it the gray-white matter differentiation. So this could be something that's abnormal with an evolving embolic stroke. So someone has an embolus, it moves to the brain and causes a stroke. You could see poor white gray matter differentiation. So this is basically the gray matter on the outside and the white matter, which, as I mentioned earlier, is darker and on the inside. And then you also need to look for any hyperdense areas in the brain, which would indicate bleeding, or hypodense areas, which can be associated with air, fat, ischemia, or tumor. So how could they be in the brain? So, well, when you have trauma, often, and there's sinus injuries, you can get something called pneumocephalus when there's air in the brain, which is actually quite benign. But it's the blood and the other trauma, which is life-threatening. And then we move on to the ventricles. So here we can see the lateral ventricles, the third ventricle, and then I will show you the other ventricles in a few slides time. And then finally, looking at the, so the ventricles, you'd examine the lateral ventricles to see if they're symmetrical, look at the third and fourth ventricles, also to see if they're symmetrical and if they are the appropriate size, and make sure there's no dilatation, because this could indicate hydrocephalus. And again, just look for any blood. And then moving on to the bone. So you can see here we have the outer table, which is this line on the outside, and the inner table, which is on the inside, just before the brain, and then the sutures. So something really important to note is that the suture lines are quite jagged, so don't mistake them for fractures. With suture lines, try and make sure that they look symmetrical. This is a good clue as to whether or not there's a fracture. And cortical bone has the highest density on a CT scan. So this is why it's very white, and it's best to look at it on the bony views when looking at the CT slices. Okay, so here we're just looking at the ventricles in more detail. So lateral ventricles, you can see they look very symmetrical. And in the center here, the dark area is the choroid plexus. The third ventricle, so very slit-like, and it should be like that, very small and slit-like. And the fourth ventricle here. And then you can just see a bit of CSF surrounding the medulla oblongata, which is completely normal. So we'll move on to looking at some pathology. So we'll start with bleeds. So we can see here, this is an epidural or extradural hematoma. It's red because it's generally caused by an arterial bleed and generally due to a skull fracture, which penetrates the middle meningeal artery. And then we see the subdural hematoma, which is able to cross suture lines. It's venous, so slower growing. Okay, so this is a bit of the intactive part. Can anyone describe what they see here? If you want, you can just put it in the chat. So describe it as if you were in an OSCE. Okay, so Rahul said pneumocephalus. Okay, that's not pneumocephalus. What are you talking about here or here? This is a bit of pneumocephalus if you were going to say that. I would agree with you, but this is not pneumocephalus. This is the frontal sinus. Okay, good. Yes, there is some scalp hematoma on the outside, but how we do this systematically? What would we start with? We'd want to confirm the patient's name, date of birth, that you have, yeah, good details of the patient, get a bit of background history. So for example, this patient was found on the road and possibly assaulted. So CT brain was done. So yes, there's a lens-shaped lesion on which side are you saying? Are you guys saying this is on? Left or right? Good, on the right. Extradural hematoma on the right. So it's in hyper. Good, right extradural. I'm just reading all the comments quickly. Yeah, so how I would describe this is right-sided hyperdense lesion, likely indicating a right extradural hematoma. There's also some subcutaneous edema or subcutaneous bleeding, and there's no mass effect. Sorry, how long have I been muted for? Strange. Oh, just the slide, okay. Okay, so can anyone tell me what this is? Showing, so subdural hematoma, yes, but which side is it on? Okay, this is a trick question. They're bilateral subdural hematomas, yeah? So again, we start with the name of the patient, their date of birth, a bit of background history. So if I said this person was involved in a head-on motor collision. And they were involved in this 4 weeks ago. So what this is actually showing is an acute on chronic subdural hematoma, which is bilateral. So the acute component where there's active bleeding is this whiter area down here, which you can see on both sides. And the darker or hypo-intense or hypo-dense area is the resolution of the blood, so the older bleed. Yeah, so they are bicrescentic lesions. Does it all make sense to everyone? And there's no midline shift here on the left. So if we move to the image on the right now, what is this showing? Good, Rahul. Convex hyperdense lesion with midline shift and mass effect. Good. So this is also showing subdural hematoma, but it's an acute subdural hematoma because of the white color of the blood. There is midline shift and mass effect. That basically just means that because of the size of this bleed, it has put pressure on the structures and shifted them towards the left. So everything is shifted towards the left. And it is again right-sided, and there's effacement of the ventricles, and actually the ventricles have been pushed over. Okay, so good. So this is just showing you again chronic bleed. So chronic bleed is darker. You can see it here, and then the acute bleed is lighter. So acute on chronic. Can anyone tell me what this is showing? Okay, scalp hematoma, yep. Yeah, scalp hematoma, but there's also a subdural hematoma on the right with midline shift. So very similar to the previous one. And can anyone describe what's going on here? So from the, what you would say in an OSCE? Yep, subarachnoid hemorrhage. So yeah, start with the patient's name, date of birth, when the scan was taken, and a bit of the history. So this patient just had let's say this patient was a young male who presented with sudden onset headache. So it's a subarachnoid hemorrhage because there's blood in the subarachnoid spaces and in the cisterns. So you can see in more detail, blood in the Sylvian cistern, blood in the fourth ventricle, blood in the, no, actually there's no blood in the fourth ventricle, but there's blood in the suprasellar cistern and in the ambient cisterns. Okay, so now we're going to move on to a little bit on CT scans of the thorax or chest. So what's important again is just making sure you're orientated and you know which view you're looking at the scan from. So if you look here, let's get the point out again. This is an axial view, so looking from top to bottom. Coronal view, looking from front to back, and then sagittal, looking from side to side. Another important thing about CT chest is that we have different types of CT chest. So you can get a spiral CT, which is the standard type of CT chest. If you're ordering CT chest, that's the standard type you would get. So it just basically compresses thick slices of the lungs into images, so none of the lung tissue is missed. But then you also get something called an HRCT, or high resolution CT chest, which then looks at thinner slices of the lungs, which are scanned at wider intervals. And it gives a more detailed image of what's actually going on in the lung parenchyma itself. But it can miss lesions between the thin slices. But it's really good when you want to look at parenchymal lung disease, like interstitial lung disease, bronchiectasis, for example. And then you can also get the third type is the CTPA, which is a CT pulmonary angiogram. So this is contrasted, and the images are taken when the contrast reaches the pulmonary artery. And it's used to look for the presence of pulmonary emboli. So you'd see a pulmonary embolus when there's a filling defect and when you can't see the contrast. Okay, so an approach to CT chest, just very briefly, is to again confirm the patient's details, the date of the scan and the background information, identify your orientation, and then what I like to do is look at the lung fields, pleura, lymph nodes, and then the heart. I think at your level, you shouldn't need to know too many pathologies, just the more important ones. I think what's really important though about CT thorax or CT chest imaging is that you need to really be familiar with what's normal and have a good understanding of the anatomy. And there are really good resources for this. I think Radiopedia is one. We just have a look at all the normal images, and then you'll be able to detect what's abnormal. So this is a really good example of going through what every single thing on the image is. So we have the pec major on the outside, sternum, ascending aorta, the superior vena cava, pulmonary vein, right main pulmonary artery going to the main pulmonary trunk, left main pulmonary artery, the left main bronchus and right main bronchus, esophagus would be here, then descending aorta, pulmonary vein, vertebra, and then looking at the lung tissue itself. So left upper lobe, right upper lobe, right lower lobe, right middle lobe, left lower lobe. And then, yeah. Just to show you the axial view or transverse view on a CT thorax. This is taken from Radiology Cafe, also a really good resource. So you can see the different arteries here, or cross sections of them with relation to the trachea, the esophagus in yellow. And you can see the apex of the left lung and the right lung. And then this is a coronal view of CT thorax. So we have aorta here, superior vena cava, pulmonary trunk, left atrium, right atrium, left ventricle, stomach, bit of the spleen here, the liver, and then right and left lung. Okay. So looking at this, we can see that the architecture of the lung looks basically normal on both sides, except for in the lower lobe. Can you guys tell me which side this is? Is it left or right? Right, good. So all of you have said it's the right side, good. Okay, moving on. So other important signs would be to I'm just trying to close these comments. Okay, so when we're looking at bronchiectasis, you could see something like a signet ring, which is basically this sign here, and the bronchi are very dilated. So you shouldn't be seeing that on normal imaging. The lung should basically look like this, or you shouldn't see much going on. And then, so these are the different signs you could see in bronchiectasis. So the bronchi can be thick-walled or a tram track sign. There could be mucus flooding or mucus plugging, sorry, tree and bud sign, and the signet ring. So here. And then this is showing what you would get in interstitial lung disease. So you get honeycombing. So you can see it looks like honeycombs. Yeah, I think those are basically the most important things. I don't really think you would get a CT chest in an OSCE. I think you'd most likely get a CT head. Moving on to CT abdomen. So again, it's just important to familiarize yourself with your orientation and knowing where, because with the orientation, you'll know where to expect the different organs. And then, so you can see the stomach here with an air fluid level, because obviously this person has probably eaten something, so there's air here. Normally there'd also just be an air fluid level because of just the hydrochloric acid and stomach contents. The gallbladder, the liver, left kidney, the right kidney is not in view in this cross section. Pancreas, so the body and the tail, spleen, yeah, and then the IVC. So this is again just to remind you of the different sections. So can anyone tell me what cross section this is? Coronal, good. So again, just familiarize yourself with what the anatomy looks like in the coronal section. Okay, now, can anyone tell me what they see? This is something you could potentially get because it's has devastating consequences. A clot. Okay. Yeah. So there's actually a ruptured AAA. So abdominal aortic aneurysm, which is ruptured. And you can see that there's a presence of blood. This is how we know it's ruptured. There's blood going into the retroperitoneal space. So generally when you're doing CT, when you're doing imaging to look for AAA, so you could see the aneurysm without contrast. Just close these comments. Okay, so you see routine CT scan without contrast, you'd see the aneurysm. And then with contrast, you'd see the blood lumen and the thrombus surrounding it. And then you measure the size of the AAA by measuring the entire diameter. So not just the size of the thrombus or the blood lumen, but the entire end to end. That'd be the size. Okay, so now I'm gonna hand over to Logan, who's gonna take you through some bloods.
Thank you, Urissa. I've just noticed that Rahul was asked, could you outline the false lumen in the previous image?
Sorry?
Could you outline the false lumen in the previous image? My interpretation of a false lumen is that there is a secondary pathway where the blood can flow through.
Yeah.
So usually if there's a false lumen roll, you'll see that light up as well. And there'll be a delineating sort of area between both kind of depicting the kind of vessel, like, you know, the vessel wall between the two lumens, if that makes sense.
Yep.
Yeah.
Okay.
Great. Okay, guys. Thank you very much. That was really, really useful, Ursa. Just wanted to ask everyone, because I don't think it was asked at the beginning. I always like to know what level are you guys at? Where are you in your sort of medical journey? Are you medical students? Are you physician associate students? What do you do? If you just comment in the chat, just for my interest. Fourth year medical student, third year AMP, brilliant. SHO, welcome, fourth year. So we've got lots of different people. Final year student with an OSCE in 2 days. Practice nurse in a GP surgery. Wow, okay, good luck. Fine, so I have been asked to deliver a session on blood interpretation. This is an absolutely massive topic, and we've tried to orientate it in a way that we've come up with some examples that may come up in your OSCEs. So I'm not going to go through absolutely every single blood test, because that's a huge ask, and we just don't have enough time. But I think what we'll do is make it really interactive and give a few examples that could potentially come up in an OSCE, and an approach to each patient that you may come across. I hope that would help. So general principles for any OSCE, you would start with your wiper QQ. So you would wash your hands, introduce yourself, ask explicitly for permission, expose the patient if that was appropriate, reposition, ask if the patient would like a chaperone, and then ask if they're in any discomfort as well. I think with COVID being a recent sort of development, it's always appropriate to say I would don the appropriate PPE as well. I'm not sure if I'll get you to do that. I would definitely verbalize it. And you can do this whilst you wash your hands. I think the general principle is finding out why they had bloods taken in the first place. So get a really basic history, what brought them into the setting that you're seeing them in. So that could be A&E, that could be GP, that could be anywhere. Gather sort of information and a bit of context of why they're here today. Then you want to explain, or basically ask the patient how much information they would want, and then explain the findings as appropriately as possible, and then summarize your findings in a way, making sure that the patient is, one, safe, and two, that they understand what their potential diagnosis is, and then finally coming up with a plan that they don't fall through the cracks. So do they need repeat blood tests? Do they need other investigations that day or in the coming weeks? And it's really important to kind of get that overall plan and make sure the patient understands it, so you're delivering sort of safe and efficient care. Just go on to the next slide, please, Ursa. Thank you. Brilliant. So basically what I've said, so I'm not going to teach you how to interpret every single blood, because it's a huge topic, but most interpretation is basic. They will be assessing your they'll be assessing you on delivery of the message, delivery of the differential diagnosis, and tying up any loose ends and coming up with that plan. So putting the result into context, that's the real struggle. Okay, so if you just go on to the next slide. So as I've said, so you want to take a really basic history, and you want to put the results in context. So ask the patient what symptoms have brought you in that led to the test, or what symptoms have brought you in today. Explain that we would be looking at certain blood tests for common conditions, and always ensure that you're kind of excluding red flags in the context of their presentation. You want to explain the results, what's normal, what's abnormal, and you want to suggest a differential diagnosis. And then you always want to come up with a safe plan. So patient safety, as everyone knows, is the ultimate the ultimate thing in these things. So ensuring that you are safe and the patient is safe, and you've got a management plan or follow up in the pipeline. Great. So basically any explanation station, what we've kind of already said. So open questions to closed questions, you want to keep it really focused. And then you want relevant past medical history, any medication that they're on, their family history, social history, do they smoke, do they drink, etc. And any surgical history if that's appropriate as well. And then managing the station itself, so discussing the results. So be prepared to speak about the normal results and making sure you reassure the patient, but explain the results in the context of the patient. And we'll go through a few examples of what I mean by that in a second. You want to, certainly in my OSCEs, I was asked several questions from they were an actor at that point, but they're basic questions like, what does this blood test mean? Is it dangerous? Am I safe, for example? So just anticipate them creating a bit of a dialogue. It's always important to kind of anticipate that, because sometimes you can rehearse a script and then be thrown off slightly. So it's good just to be aware of that in any of your OSCEs. And then just keep checking their understanding of what you've said. Try to stay away from medical jargon, just the really basic stuff that you've probably all really been taught. Try not to interrupt when the patient is speaking. That can really put you down in points. And essentially, this is a point building exercise, isn't it? You want to pass the OSCEs, so making sure that you give the patient or the actor or actress the time to explain their concerns or for them to speak. And then always ice your patients, so ask it about their ideas, what they think it could be, if they've got any particular concerns, and what they're expecting going forward. That's a really good way to kind of close off the consultation as well. And I've said that don't use medical jargon. And then finally, you want to agree a plan. Great. So general principles that I like to keep to. So the first bit is gathering the information. Thank you. Just go back and gather the information. So as you said, symptoms leading to the test, common conditions, red flags. So for example, just go back, thank you. Hematuria in a menstruating 20-year-old female versus a 65-year-old male. So if you can comment in the chat, would you think that they are sort of equivocal risk, or do you think that you'd be more concerned about one patient than the other, just from that sentence? So Michelle saying red flag for 65-year-old male, and then ICE ideas, concerns, expectations, more concerned about the 65-year-old male, red flag. Exactly. So I would be much more concerned about a 65-year-old male presenting to me, say in the GP practice, with hematuria, whether that's frank or sort of microscopic. Yes, the big thing you would want to rule out is urological malignancy. Great. And then so you want to explain the results to the patient, normal, abnormal, suggest a differential diagnosis, and then you want to suggest in sort of ongoing plans. The way I like to do it is do some bedside investigations where you can do that in the practice, for example. So things like an ECG, further blood tests, observations, a urine dip, blood sugar, and you want to go on and suggest some more blood tests, which can be done on the same day. Any imaging that's required, or any special tests, or any onward referral to the specialty that may be appropriate for your patient. I'm just going, so the other sentence is anemia in a patient with dysphagia versus a known dialysis patient. That's a bit tougher. Maybe the SHOs amongst us might know this, but what about the medical students, the AMPs, etc.? Yeah. So are we either saying dysphagia? Yeah, great guys. So yeah, you're completely right. So dialysis patients are known to kind of run low hemoglobin. They've got anemia of chronic disease. And anemia in the context of dysphagia is a red flag, so you want to act on that a bit quicker. Brilliant. Great. So common bloods to interpret. Can you explain these without jargon? So these are some of the common examples that we were thinking that could come up in the OSCEs. So full blood count plus your hemopinics, thyroid function test, your renal profile or your urea and electrolytes, bone profile, LFTs, liver blood tests, and hyponatremia screens as well. So those could all potentially come up. So it might be worth, we're going to go through a couple of these examples, but it might be worth noting these down and just revising, sort of going through some of the blood tests and their interpretations. Okay, go on to the next slide. And also, what the examiner might ask you to do is to explain certain definitions. So, what is hemoglobin? Or the patient might even ask you to explain what hemoglobin is, what your platelets are, creatinine, the T4, ALT, albumin, all of these things you could be asked in your OSCE. I'm happy to go through these, or we can just go on to the examples. I think the examples would probably be more beneficial. Great, so I'm going to speak through this first example, and then everyone else can, we can get everyone else involved in the next couple of examples. So you're an SHO on placement at the GP. Joe Bloggs, who's 23, has some routine blood tests. And then I'm asked to please explain and answer any questions. So just going through all of these blood results. So is anyone concerned about the hemoglobin, the HB? You can comment in the chat if you want, guys. So is anyone concerned about the HB? No. White cells, platelets, sodium. No. What about the creatinine at the bottom? Okay, so I think everyone's noted that the creatinine is slightly high, isn't it? And if I were to tell you that Joe Bloggs was a large male and they were an athlete, would I be less concerned? So I'd be less concerned. Yeah, so if you go on to the second slide. So basically you want to gather the information. So routine bloods required for work because the patient is an athlete. So it's a kind of occupational health workup. The patient feels really well, no flags, no urinary symptoms. They've got a history of migraines, but they haven't had any headache recently. And I basically would say, look, all of your electrolytes, your salts are normal. Your creatinine is a measure of muscle building and indicates kidney function slightly high. But in the context of the background of the patient, I wouldn't be concerned. But I think the safest thing to do would be to carry out a further blood test in 3 to 6 months. Or if I would definitely safety net in that if they develop any other symptoms, so like muscle cramping, hematuria, anything like that, or they became more unwell, to come back sooner for a repeat blood test. And I think it's a fine balance of reassuring the patient and explaining, although we need to keep an eye on this, it's probably normal in the context of the background of the patient. I think everyone got that, didn't they? So why don't we go on to the next example? Okay, so be really grateful if everyone could comment and get involved. So you're an SHO on placement at a GP. Mary Whitehouse, she's a 37-year-old and has had some bloods taken. Please explain the results and answer any questions. So the hemoglobin, are we concerned about that? So I'm getting iron deficiency anemia. I'm getting a microcytic anemia. Okay, so it's, yeah, so the HB is low. So that's the first step. And the next step, we would be looking at the MCV. So the mean corpuscular volume. So is that low or high? MCV right at the bottom. So MCV is low, which would go with a microcytic or an iron deficiency anemia. And we're looking at the iron levels. So iron is 4 when the normal range is 10 for 3. Great. So if I were to say patient is feeling tired all the time, they had normal menstruation, but they've been vegan since the beginning of lockdown, and all they've really eaten are crisps. What is your interpretation of that? Would you be less concerned? Would you be more concerned? Iron deficiency anemia would be expected to be hyperchromic, however, hence would not be provided. Yeah, we haven't gone into that much detail, but note that's a good point. So if you go on to the, yeah, so it's I think it's a nutritional based anemia. If we go on to the next slide. So feeling tired all the time, vegan, it's an iron deficiency anemia. Reassure the patient that although it's sort of an iron deficiency picture, we can treat that with diet and iron supplements, and we can then, as you reassure the patient, you have booked an appointment in a month for a review. So we've kind of done everything there, haven't we? So we've gathered the information, you've managed the stations, you've explained everything, you've reassured the patient. So just on the off chance, if the patient says, "Oh my goodness, is this serious?" I would probably say we wouldn't want it to get any worse. It is treatable. It's like the nutritional, sort of a nutritionally affected anemia, and we can keep a very close eye on this with regular review in the GP practice. Okay, so if we go on to the next slide. So you're an SHO at GP, and Joseph Simpson has had some blood tests taken. So let's go through the results again together. So HB is just in the context of time. So HB is low. The MCV is also sorry, I didn't hear that. Yeah, so it's a microcytic anemia, and given that the patient's age profile is a bit higher than the other patient, would we be less or more concerned? And what would your differential diagnosis be? Exactly. So yeah, I would definitely be a bit more concerned if I saw this patient in the GP practice. And the big thing that you would want to rule out is malignancy. Exactly right. So what would we offer this patient? Yeah, so we've taken a detailed history. They've explained the symptoms. The symptoms were a bit of weight loss and being tired all the time. So that's what prompted the bloods. We've explained that you've got a microcytic anemia, and we would. Sorry, I'm losing it slightly. Everyone's said quite a bit. So Evans Carr said OGD, CT, HPC, colonoscopy, OGD, fecal occult blood. So yeah, exactly. So I think everyone's correct that we have identified that there's a potentially serious underlying condition, and they do need further investigation. So that would be in the form of some bedside tests such as a urine dip, an ECG, repeat blood tests, and for example, a fecal occult test, and then a 2-week wait referral, which is a cancer referral to the specialist for colonoscopy or OGD or whatever it would be a colonoscopy in the first instance. Okay, so everyone's recognized that. and this is what we've kind of said. So feeling tired all the time, has lost some weight, no other symptoms. We've explained that it could be a potential serious diagnosis. However, we were going to review that and follow this up in an appropriate way. And the 2-week wait referral, so any cancer sort of referral from GP would be going under the 2-week wait referral. So they would be getting a colonoscopy or further imaging within 2 weeks. Brilliant. So in a patient who, so 928565, it has asked about why we're concerned about cancer. So in a gentleman, I think the red flags, over 55, weight loss in a microcytic anemia picture, colon cancer is a big thing that we need to rule out. And that's why GP is really hard, because sometimes the symptoms aren't that sort of noticeable, and in this patient they only had a bit of weight loss. So yeah, you have to think about what the worst thing it could possibly be is. Okay, so I think explain the cancer concern about that. So if it were me, how I would explain the cancer concern without worrying the patient too much, I'd be honest with the patient. I'd say, so I'd basically ask them how much information would they want to know, and then make sure that their expectations line up with what you want, what information you want to provide, and say that your blood tests show X, a microcytic anemia picture, in the context of your history, so weight loss and your age category. We would always be concerned about cancer, and I don't think it's wrong to say cancer. It's, you know, I think it's better to be open and honest with the patient rather than keeping any information from them. Yeah, you have to be honest, and you'll get marks in your OSCE if you're honest. Great, so I know we are running over time slightly. We've got a few more examples, if that's okay. So next one, so Julia Waters, your GP, Julia Waters has done blood tests. So we're looking at HB, which is low, MCV, which is low, and we are looking at ferritin, which is low. So that is again, microcytic anemia. But if this patient had heavy periods, they were otherwise well, would you be concerned in a 22-year-old? No. Reproductive age group, wouldn't be concerned. Okay, would we just leave the patient, or would they need any further bedside tests, investigations, or treatment, or any follow-up? So Keris is saying iron supplements, supplements, brilliant. And we'll check BP, HB, and follow, give some iron supplements, and 3-month review. That's perfect. So as long as you identify it, treat it, and then you can organize review in a couple of months' time to make sure it's not getting worse, and then make sure you safety net as well. So explain that if you get chest pain, shortness of breath, you feel more unwell, you need to either come back to the practice or go to A&E. I think that would be appropriate as well. Brilliant. So if we go on to the next one, we've kind of said all that, haven't we? Great. So I've given you a bit of a clue. So thyroid function tests. So you're a final year medical student on placement at a GP, and Janet Smith comes in and she's had some blood tests taken. Please explain the results and answer any questions. So just, sorry, going back, Francesca's asked, maybe treatment for menorrhagia, investigate the causes, could be primary, could be secondary. Absolutely, it could be. That's definitely something you could mention in your previous example. But for the context of this OSCE, I think that what we said is appropriate. But yes, please think about other causes as well. Yeah, so white cells are normal. TSH, is it low, high? Is it normal? So TSH is low, and the free T4 and T3 is, I would say, high. Yeah, so in the context of this patient, so she has lost a bit of weight, she's feeling a bit sweaty, she's got on examination, she's got no eye signs and no other concerning features. Yeah, so I think the first thing to do is to recognize what this could be. So you're completely right. So hyperthyroidism, and that's usually because the thyroid produces excess T4, T3, and that will decrease the TSH. It's a primary cause. Oh, and I forgot to mention that she's got a lump in her neck, so that can go with hyperthyroidism. But you want to explain the diagnosis. So could be hyperthyroidism, could be Graves' disease. She's not got any features of thyroid storm, and you want to explain that it's a common autoimmune disease, which is characterized by hyperthyroidism due to antibodies. And in GP, you can commence treatment, but it's important that there will be follow-up with the specialist if, for example, her bloods or her clinical picture is getting worse. Okay, so the next one would be, so you're a foundation doctor in A&E, and Mary Poppins has come in, and you want to explain these test results. So her history is that she's had a bit of weight gain. She's had sort of hard stools. She's got thin hair and she's really tired, and she couldn't get a GP appointment, so she came to A&E. Yeah, so the TSH is slightly high. The free T4 is low. Free T3 is kind of normal. Her thyroid peroxidase antibodies are negative. So because of the free T4 being low from the thyroid gland, it's reduced negative feedback, which increases the TSH level. So this is a primary hypothyroidism. Yeah, exactly. These are quite tricky scenarios, but it's just an example of what could come up, really. Yeah, exactly, Rahul. Yeah. So the defect lies within the thyroid. So you want to explain the diagnosis, reassure that it's treatable. Symptoms can be improved. If an ED, I would definitely ask the GP to review. I don't think they need to do any more blood tests in ED if they're well, but in the workup, you need to do sort of bedside tests like an ECG, urine dip. And if you are concerned, just ask the medical team or the diabetes specialist or the endocrine specialist for any advice as well. So just involving the correct teams is quite useful. Great. So those are just two examples that could come up. Let's just go on. We've got two or three more examples, and I hope this is helpful. So you're a medical student in GP. Patient XY, who's 27 years old, they've had some blood taken. You want to answer or explain the results and answer any questions. So let's just go through them. So white cells are normal. ALT, would you be concerned about ALT? No. AST is also normal. ALP is also normal. So this could be a very real example that you may get in an OSCE, and the bilirubin is up. Exactly. So it's an isolated hyperbilirubinemia, and he'll be yellow. He will be jaundiced. Yes, G. He will be jaundiced, and that's why he came in, because he was jaundiced and he was concerned. But he's otherwise well. What would the differential diagnosis be on this patient? So Aaron said Gilbert's, Laura said Gilbert's, and Wendy said hemolytic anemia. So no recent travel, also a very good question. So the two primary differential diagnoses is Gilbert syndrome and the hemolytic anemia. So G, what would cholecystitis, what picture would that show? We'll go through it in a second. So cholecystitis would usually show an obstructive picture. So they would have increased bilirubin, yes, but with other abnormalities, so increased ALP, maybe a high white cells as well if they were unwell with it. So let's just go over this example. So well and self, no abdo pain, no alcohol, and jaundice. So that's whether we're concerned. So we'll need, you're explaining the diagnosis that yes, the patient is well, but it could be Gilbert's disease. So about 75–80% of patients with that type of blood picture is normally Gilbert syndrome. But we'll need further tests, including a blood film, haptoglobin, LDH levels as well, and may need further gastroenterology or hematology referral for non-invasive liver screen, or if it is a hemolytic picture, hemolytic anemia, then hematology will be involved as well. So it's just, in an OSCE, it would just be verbalizing that I would get the appropriate specialties involved as well. So how would you describe Gilbert's to a patient? So Georgia, I would say I can see that you were concerned that you've had changes in the color of your eyes or the color of your skin. That is why we've done the blood tests. Today, your blood tests show a raised bilirubin, which is a component of your blood that directly affects the bile, and there's a buildup of that. And there's a couple of reasons that it could be. Sometimes it's a genetic component, like Gilbert's, or sometimes it's other causes like breakdown of your bloods, like hemolysis. I think it needs further investigation and discussion with the appropriate teams, gastroenterology or hematology. That's what I would say. I hope that helps. Yes, as a prehepatic cause of jaundice. Yeah. So this is just a few little key points that I like to remember. So your AST and your ALT are hepatocellular enzymes, and usually in hepatitis, ALT is greater than AST. In AST that's greater than ALT, it's usually an alcoholic liver disease or very advanced cirrhosis. ALP, which comes from the biliary epithelium, but also comes from the bone, so it can be either a biliary source if your ALP is increased with an increase in your GGT, which is another enzyme. So it can be either obstruction, infiltration, or congestion from right-sided heart failure. But if the ALK phos is increased with a normal GGT, just think of a bone, sort of like bony mets, or sort of myeloma as a differential as well. And then an isolated bilirubin increase is a prehepatic cause, so Gilbert's or hemolysis. So I think this could definitely be an example that could come up in your OSCEs, and it's just worth having a little look at the different patterns of LFTs in certain conditions, just to have a bit of a plan going forward. Great. So go to the next. So this is the last example. Thank you for staying with us. So you're an SHO on placement at a GP. Mr. X has had some routine bloods, and we need to explain the results and answer any questions. So white cells, are we concerned about the white cells, anyone? No. HbA1c is 42. So Francesca's saying fine. Michelle saying pre-diabetes. Fasting blood glucose, so normal range is 5.6, and in this patient 6.2. G saying pre-diabetes, and the oral glucose tolerance test. So I hope everyone knows what we mean by oral glucose tolerance test. You ask the patient to fast, they drink a sugary drink, and then you repeat the bloods or the blood sugar in 30 minutes, 60 minutes, 90 minutes, and see their response. So in this patient, their HbA1c is slightly borderline, isn't it? So if I were to say that their BMI was 27, they had 2 takeaways a week, they drank a bit of alcohol at the weekends, what would your plan be? So first thing to say is everyone's correct that it's a pre-diabetes picture. So how would you manage this patient? Exactly. So everyone's saying lifestyle measures, and that's great, guys. Yeah, improve diet, exercise, reduce weight, feels well. So the BMI is slightly up, drinks moderately at the weekend, eats a couple of takeaways a week. So you want to explain the diagnosis. There's a risk of developing disease, and they will need ultimately sort of intervention as a sort of advice, lifestyle advice changes, and then follow up. So follow up in 6 months, say, once they've implemented those lifestyle changes. And I think that these examples, everyone's got every single example correct. It's just thinking, what does this patient need? Do we need to act on it immediately, or can they be reviewed in the community in a couple of weeks, couple of months? And every single person here has, I think, understands that, which is great. So how do we actually know that it's not diabetes? So if we go on to the next slide, this is the diagnostic criteria for diabetes. I hope that helps. So the HbA1c has to be over 47, so that's diagnostic. And in this patient, it was 42. And essentially, your HbA1c is your glycosylated hemoglobin. So it's an average of your blood sugar, in simple terms, average of your blood sugar over a 3-month period. So there are diagnostic criteria for diabetes. And it's also worth asking the patient what they want as well. So some patients may not want to start tablets. And although, metformin is the first line medical treatment for diabetes mellitus type 2, they may not want to try that. They may want to try some lifestyle changes and come back and see how they get on. So I think you've all done really well there, guys, and thank you for participating. I hope that kind of helps. So ultimately, you want to gather the information, explain the results, and then come up with a bit of a plan. And if the patient needs any further investigation or treatment, making sure that that is verbalized and kind of agreed with the patient as well. These are really good resources that we always use every single week. OSCE Stop, OSCE Age, really good. I personally like Almost a Doctor. That was a bit of a really great resource for me during my finals. That was really helpful. And then don't underestimate the NICE guidance as well. The NICE guidance is very, very useful. And then for URIS is part of the top Radiopedia and Radiology Cafe as well.